Dear my colleagues, soft cataracts are challenging cases. As you know, they may have difficulty to be chopped, and also higher visual acuity levels of these patients may increase our stress. Furthermore, today we increasingly have to do clear lenses for presbyopic cataract surgery, so we need to choose safest method to get over these challenging cases. Now I would like to mention about the technique named as half-moon supracapsular nucleophractis. We firstly described this technique in 2008 and published in Journal Cataract Refractive Surgery. With this article, we showed the superiority of this technique over classical stop and chop for efficacy, functionality, and safety. In the following years, this technique took place in some other journals such as Cataract Refractive Surgery Today and Ophthalmic Surgery and Lasers Imaging. I'm going to show you the critical parts of this technique with some video fragments taken from 4 different soft cataract cases. You can begin the surgery as it was classical start. You may prefer using short incisions. Incision size will not restrict your technique. Capsular axis will not be different from your classical technique. Ideal diameter will be 4.5 to 5 mm. Shorter or larger than this has little possibility to cause some problems in this technique. At this stage, we have to do hydrodelineation and hydrodissection. By this way, we can pop up the distal nucleus over the capsular axis edge. During hydrodissection, BSS will be captured between posterior capsule and nucleus, and its anterior pushing effect will prolapse out the distal nucleus. At this point, the view under the operating microscope will extremely look like a half-moon. That's why we named this technique as half-moon supracapsular nucleophractis. By the way, you may not prefer to create hydrodelineation. It's not indispensable, but it's done, the process will become much easier. For hydrodelineation, if you angle your 27-gauge flat cannula downwards with 45 degrees to the nucleus surface, you will see that hydrodelineation is an easy procedure. Following, you have to change your direction upwards to under the capsular axis edge to make hydrodissection. You may have thought that all the cases were the same. Actually, I would like to show you that this technique could be performed as almost in standard model, or it can easily be repeated. In the nucleophractis phase, basically horizontal Nagara chop is done, but with only one difference. This time you can do the chopping maneuver under direct visualization in anterior chamber. As you know, in Nagara technique, you have to chop the nucleus within the capsular bag, reaching to the nuclear equator, generally under the iris, without seeing the beginning point. This was the most important disadvantage of Nagara technique. After first crack, if you want, you may send the heminucleuses into the bag and continue endocapsularly in order to protect corneal endothelium. But generally, soft cataract pieces tend to come anterior chamber. Like all the chopping techniques, you will not probably use much ultrasound energy to remove the rest of nuclear material. Now I will give you some other examples from my other cases. As you see, I prefer using round or olive choppers in this phase. I always find them quite reliable. At this point, I would like to remind another advantageous security factor. After hydrodelineation, we have epinuclear tamponade in front of posterior capsule, so you will find this technique quite safe, especially while you are dealing with soft cataracts. If the cataract is too soft, the technique may not be demonstrated well. But in this case, things will be easier. As you see in these last 2 cases, material could be quickly cleaned without additional chops. Cortex removal again won't be different from classical phacoemulsification procedure. Sometimes hydrodissection after hydrodelineation have been insufficient to separate epinucleus from capsule. This time, you may have to clean epinucleus within irrigation aspiration phase. As I said, we frequently perform cataract surgery on clear lenses for refractive lens exchange. It will be useful to check the proper position of IOL with the overlap of Purkinje reflexes at the end of the surgery. As a result, I would like to recommend half-moon supracapsular nuclear practice technique, especially for soft cases, to achieve successful results and to do your surgery under secure conditions.